extubations in pediatric cardiac surgeries. Today, I'm delighted to invite you to our fascinating interactive topic discussions between Sierra and Sitkus hospitals entitled Fast Tract Anesthesia for Congenital Cardiac Surgeries, How to Safely Extubate on the Operating Table. Thank you, Dr. Thilopong, the CVT surgeon at here, for considering the importance of these issues and collaborating to create this session today. Now, I'm thrilled to let you know that we have a special guest who is experts on these topics, Professor Kathleen Taylor. Professor Kathleen Taylor is staff pediatric cardiac anesthesiologist at Department of Anesthesia and Pain Medicine from Hospital for Sick Children, Toronto, Canada. She graduated with the clinical fellowship, adult anesthesia, pediatric anesthesia, and pediatric intensive care from Australia and again from Canada. She has many international experiences, including board member of Congenital Cardiac Anesthesia Society, CCAS, Wellman of USA, and past president of Canadian Pediatric Anesthesia Society. Her educational and research aim at improving the practices and focus on pediatric populations. And now she stays with us. Welcome, Professor Kathleen, and please.
Thank you. Thank you very much for the introduction. I hope you can hear me okay. I'm delighted to be here and very grateful to you all for the invitation and for coming in extra early this morning to listen to this talk. I'm just trying to, there we go. So I have a couple of objectives today, but I've kept this deliberately very loose because I understand I'm speaking with colleagues and I'm sure you have your own experiences. And so I wanted to keep this as interactive as possible. I'm going to review some of the evidence supporting this fast-track anesthesia in congenital heart surgery, but also give you some caveats and some caution when you go and pursue your literature on your own, because it is difficult to generalize the experiences of some centres to indeed our centre and quite likely your centre. And then I'll describe our experience at Sick Kids, which was really a very organic process, and then describe the fascial plane blocks that we use daily. And that's what I really think have made the difference in this area and enabled us to extubate our patients. I have no real disclosures apart from this one that I think is important for this talk, because I think we've all been to talks where there's a regional anesthesia guru who talks about something that really isn't within the skill set of the average anesthesiologist. And the blocks I'm going to talk to you today about are really very basic. They're kind of in a group of what's called baby blocks, which are expected to be a realistic attainment for any anesthesiologist. So what I'm describing today is not especially difficult. This is a photograph of where I work. This is the Hospital for Sick Children in Toronto, Canada. This is summer, which in Canada is pretty short, I have to say. It's about 12 weeks. And we are the largest cardiac hospital in Canada, and Canada's population is just approaching 38 to 40 million, I understand. In Toronto, we serve the children of Ontario, which is the most populous province in the country of about 15 million. But we also have patients from some of the smaller, lesser populated provinces in both east and western directions. And I think that's one of the things about Canada is that we have very low population density, unlike your centre. And so we have patients from all over the country. As part of our ongoing program evaluation and maintaining standards, we belong to a group called from the Society of Thoracic Surgeons, which is based out of the United States. And I am the local data lead for Sick Kids for that data. And I present this here just to give you some idea about our centre. and our outcomes. So I think it's sort of a bit of a truth-telling slide, this one. What happens in North America is that you can sign up to join this STSS database. And at the moment, there are over 1,200, that's 1,200 hospitals that have signed up. And they report their outcomes for both adults and pediatric cardiac surgery. Periodically, at least twice a year, someone from the group will come and do random audits of the data from each site, so that the data we're presenting here is robust and as truthful as you possibly could get, I think, from registry data. And this will show you some of, we are blue, so you get these reports, which is the participant hospital, and then the pink is the median hospital from the STSS database. And this is the median from sites who have cases more than 10 of each index operation. And so you can see as a general gestalt from our place in that our mortality rates are better than most of the averages for the STSS. There's a couple of outliers. This Truncus group here, of which there were 2 deaths in 7 patients over these 3 years. And you can see the postoperative length of stay here in the AV canal group. And when you look at the confidence intervals, you can see that the range, it only really takes 1 patient to skew these figures when the numbers are so small. But this will give you some idea about where we sit amongst the median of American hospitals, which helps you to understand the next and the subsequent slides. This slide also comes from the STS database, where we record the patients who are extubated in the OR. And this will give you some index about the type of patients and how many patients we extubate. So the red in the top bar is sick kids, and this graph here is the median of the hospitals from the STS data set. A couple of things to note. You can see that very few of us, including ourselves, are extubating neonates in the operating room. We extubate about 10%, and I'll talk more about neonates later. But from the other age groups, we extubate more than the median STS hospitals. We don't do adults at our site, so that number is irrelevant. And we'll extubate maybe 87% of our ASDs, 46% of our VSDs, 62% odd of our tetralogy fellows, 20% of the AV canals, about more than 2/3 of our Glens or bidirectional cavopulmonary shunts, and about 84% of our Fontans. We're not really extubating our Norwoods, and most centers in the US are also not extubating their Norwoods in the operating room. So you can see I'm talking to you today about this topic, having worked in a hospital that probably extubates more than many other centers in North America. But I would say that we're not the most aggressive hospital here, in that we're not extubating Norwoods. There are a few people who are doing that. The other important thing when we start talking about early extubation and ERAS protocols is, what do we mean by early? And this is partly what I alluded to in the beginning, is that early means different things to different people. And so what this slide shows, again, from the STS data set, shows if you're not extubated in the OR, then when are you extubated? And I think this is important because a lot of the literature you will read might say that early extubation is within the first 6 hours of chest closure. Indeed, some people will report the first 24 hours of chest closure, which feels a little bit like cheating, I have to be honest. And what I'm going to focus on for this talk is actually extubating in the operating room, which is what we are doing more and more frequently. For those children that we're not extubating in the operating room, this kind of bubble graph will show you that most of our children are still getting extubated earlier than the STS average, which is the pink, and sick kids is the blue. And this will give you time on the y-axis. And you can see from these numbers that generally we are pro-extubation at our center. The way we come around this is really with regional anesthesia. And if you look at extubated in the OR, for us in the period of 2019 to 2020, it was 45% globally, and then went up to 51% the following year. When you look at the STS averages, it's about 30% for both and pretty static, whereas we're going up about 5% year on year. And our next data set, which will reveal 2022, is also higher again. I think the reason that we've made that work is when you look at regional anesthesia. We started in 2019 with 34% of patients getting some type of regional anesthetic in the operating room. And in the next 12 months, we've increased that to 65%. And most of those blocks are the blocks I'll be discussing today. But that's really been the big signature change in our practice that's enabled us to extubate more and more patients year on year. And before I sort of get into the nitty gritty of how we do it, I want to kind of explore a little bit about why we do it. And I'd like to come to you to say that, you know, we originally had this, what really triggered it was we were trying to be more efficient in our ICU bed utilization, and we were trying to get patients through the ICU. We were finding that patients would spend longer in the ICU, and we were unable to get more children in. And so we were having idle operating time during the week. And so we started to look at our global practice, went and visited some other sites and recognized that there were ways that we could speed up the patient journey as part of these ERAS protocols. And we do have protocols that determine when chest tubes come out and the way chest tubes are placed and the whole patient experience for some of our index operations like ASDs and VSDs. And globally for the whole program, we've started now to try and extubate patients earlier. We found that's better for staff because staff are rostered to work during the week, and we're able to perform surgery during the week and not have to play catch up on the weekend for elective patients, which is what we were doing because we just didn't have beds. And it's certainly more efficient for resources. We found it's better for patients, and we have some data that suggests there's fewer complications and definitely a shorter length of stay by doing this. We have, during this journey though, encountered some roadblocks, and I think that's something that is worth your team exploring if you decide to adopt this. And one of the key questions I think that needs to be asked is, what is an acceptable failure rate? And who's going to intervene if the extubation doesn't work and the patient needs to be re-intubated? And part of exploring that is what facilities are available for the immediately extubated patient. And that requires the whole team and a process approach. So even though we're talking as anesthesiologists to other anesthesiologists, this can't really happen if only anesthesia are on board, and you need to have ICU and the nursing staff and everybody else, including surgeons, on board to proceed with this. And patient selection is obviously crucial. And I'm going to tell you a bit later in this talk sort of how we started and how we keep pushing the envelope a little bit to try and extubate more and more patients. There are some good physiological advantages to extubating patients early, and so I think the science is relatively easy to sell. We know that there's an increase in venous return and an increase in cardiac output, and that can be particularly advantageous for some of the circulations post-congenital heart surgery, like the Glenn and the Fontan. We know as general anesthesiologists that as patients emerge from their anesthesia and they still have an endotracheal tube, they often get a bit hypertensive and tachycardic, and they have lots of endogenous catecholamines around that time of extubation. And I find that that's much easier to manage as an anesthesiologist in the operating room than to have someone in the CCU manage it, which at our site, typically people get a bit anxious that the patient's hypertensive and they've got their tube, and so then they resedate them because they want to manage the blood pressure, and they usually give something relatively long-acting, it's like a benzo or a long-acting opiate, and then they kind of delay the possible extubation for a few hours, and then the patient lightens again and they get tachycardic and hypertensive again, and then they get more sedation. And so managing that peri-extubation time period and those hemodynamics, that often requires one-to-one attention, maybe some short-acting drugs to manage the hypotension if it's particularly problematic. I think that's much better to do in an operating room. And also, you know, if you extubate patients early, you might get an increase in CO2, which may increase the pulmonary vascular resistance. That's a bit of a double-edged sword. There's certainly some circulations that's going to be worse. There'll be some that might be better. You might get some more cardiac output in a Glen, for example, if they're a little bit hypocarbic, but you have to watch their pulmonary vascular resistance at the same time. There are clearly some disadvantages. And patients with inappropriately treated pain can increase their SVR, and that can be deleterious for their circulation. And you lose some of the afterload benefits once you remove the positive pressure ventilation. There isn't a lot of research out there that describes these physiological benefits in such a nuanced way, but there is one paper from British Columbia, and that group looked at their early extubation patients and found that when they were extubated in the operating room, the patients had their inotrope infusions in the ICU for about 8.7 hours longer than patients who went to the ICU already intubated. It's a bit unclear to me when I read that study why that is, and it might be that the patients who are not extubated go to the ICU and they have an endotracheal tube and they're receiving sedation as opposed to anesthesia. So they have lots of endogenous catecholamines, which are driving their hemodynamics, whereas the early extubation group needs some extra support. So when we talk about and consider patients for extubation, who are we really considering? And this is sort of a general kind of shopping list that we have in our heads to think about patients who might be appropriate for extubation. And nothing here is particularly new or fancy, I have to say. So we look for patients who have a relatively stable hemodynamics with stable rhythm and are on minimal vasoactive agents. I must say, though, that, you know, low dose epinephrine, like 0.02 mics per kilo per minute, would not prevent us from OR extubation. And we sometimes find that once we remove the effective anesthesia and they have some of their own endogenous catecholamines, we can turn off those vasoactive supports. You want patients who are warm and well perfused. You want patients who've had an echo that shows minimal residual dysfunction after their cardiac surgery and no significant residual lesions. Ideally, you want them to have minimal ongoing bleeding, although we don't, as a rule, say that some bleeding is a contraindication to extubation, but we certainly don't want out of control bleeding and active resuscitation in freshly extubated patients. So we would leave the endotracheal tube in those patients if that was the situation. We aim for a rectal temperature of more than 35 degrees. And we choose patients for whom the intubation was relatively easy to start with, and they have relatively normal ventilation, or they're patients who we think are quite marginal. So, for example, a bidirectional Glen who has relatively high CVP/PA pressures and is sort of limping along, and but everything else we've attended to and we can't improve. We might give them a trial of extubation, hoping that that incremental benefit under spontaneous ventilation with that negative pressure and that suck to get some more pulmonary blood flow, that might be the thing that just gets them over the edge and out through the early extubation period. And we can certainly, you know, we don't have to extubate to a face mask. Sometimes we extubate to CPAP or some other ventilation support for those patients, but we do try and get the tube out as quickly as we can. Obviously, if you're going to wake patients up and extubate them, they need to be appropriately analgesed. And if they're not and they have pain, then they can splint and you end up getting yourself into a bit of difficulty trying to manage their ventilation with the pain and load them up on opiates after the tube's pulled. So we tend to do that before. And anecdotally, we find that the patients who come to the operating room having already been ventilated in ICU for a few days, they're not really candidates who can be extubated readily. There are some exceptions, of course, but generally that's the case. And as I mentioned before, typically we do not extubate neonates. What about the people that we need? So We look at the patient factors that I've already mentioned, but we also look at the resource factors at the time when we're contemplating extubation. And I think one of the key things is that if this goes badly and the patient needs to be reintubated quickly, who is around and who can do that, and are they able to do that? And so this speaks to the local factors as to where your patients will go after you extubate them. Do they go to a recovery type environment? Do they go to an ICU environment? Are there anesthesiologists in your ICU or someone else appropriately trained? And can they re-intubate if this doesn't work? So typically, and in a practical sense, we'll still extubate patients at 9 and 10 p.m. because we consider those business hours at our site, but it would be uncommon for us to extubate a patient and return them to the CCU at 2 and 3 a.m. in the morning, mainly because the CCU staffing is such that we have concerns about how available someone would be able to intervene if they needed to. So we might leave that patient till 6 a.m. in the morning. The patients who we are reluctant to extubate for sort of administrative reasons like this, what we might do as a halfway or interim measure is we set them up for early extubation within 6 hours of arrival. And you'll see a lot of the literature actually reports the first 6 hours as their sort of early extubation outcome. And so that means we'll have patients appropriately analgesed, spontaneously breathing with minimal pressure support on an endotracheal tube. And then when ICU has them settled in and they're comfortable, they can pull the tube relatively quickly afterwards. What this process has allowed us to do is that we actually sometimes have more than one patient in an ICU bed in a 24-hour period. And so some of our patients will be in the operating room, they'll get extubated, they'll go to CCU for about 4 hours. We assure ourselves that there's no ongoing bleeding or any concerns. They'll be transferred up to the floor, sort of a general cardiology floor, and we can use that ICU bed for another post-operative patient. And so we do that as well. And so this process of ERAS has really freed us up to try and utilize our ICU beds a bit differently than we did beforehand. So how do we do this? And look, there's no secret magic recipe. I think like everything, there's a bunch of things that we do. But the thing that's really changed our practice, and I mentioned too in an earlier slide, is that we put regional blocks or regional anesthesia in upwards of 70% of our cardiac patients. And the block we typically use covers this area here. This is an adult. And it's called the PEX intercostal fascial plane block. I don't know how experienced you are with fascial plane blocks, so I'll just kind of do a brief kind of rundown, and certainly we can explore it more in the question time afterwards. But the thing about fascial plane blocks is that unlike direct nerve injections where you need to spend a lot of time, for example, finding the median nerve at the wrist and injecting around the perineural space, and you'll probably use a high concentration local anesthetic and relatively low volumes, a fascial plane block doesn't require such anatomical accuracy. What you're trying to do is find a potential space between two muscle layers. So each of these blocks are usually named after the muscles that you're trying to find the space between. And you use relatively low concentration but high volume local anesthetic to hydrodissect this potential space. And then the nerves traveling through that space will then be bathed in the local anesthetic that you choose to use. So we do these blocks bilaterally on all the patients who we consider will be extubated within the next day. So we tend not to do the neonates, but everybody else will get these blocks at induction. When you read the literature about this, look, it's a bit confusing, but this is essentially the nerve that we're trying to block. It runs particularly deep and then it becomes superficial, and it innervates the periosteum and the central part of the chest, so it covers the sternotomy wound quite nicely. We call it the pecto-intercostal fascial plane block, or a PEX block. And the area we're targeting is this layer here. What you'll also see in the literature is this layer here, the transversus thoracic plane block. Same nerve, but different muscle layer. So for this block, you're trying to go a bit deeper. There's a couple of reasons why we prefer the former, but the latter block has certainly gained some traction in the literature. The former block is relatively easier to find in that the sonoanatomy or the ultrasound anatomy is much easier to delineate, and we use ultrasound for all these blocks. And we consider this to be relatively safe territory. These are your internal mammary vessels, and so we are some distance away with our local anesthetic, so we think this is a very safe block. Although certainly you can get very good results with this block here. The dangers, however, are its increased risk of pneumothorax, increased risk of pericardial puncture on the left, and more concerns about sort of low damage or infiltration to local major arteries close to the block. What's important as a takeaway is you're still getting the same nerve, and because it's a fascial plane block, you essentially just need to get a reasonable amount of volume, and I would recommend 5 mils per side for a neonate, 10 mils per side for a child, and 20 mils per side for an adult, to create a bath for this nerve as it passes through this muscle layer. There is some evidence sort of in this fine print that if you have a redo chest and lots of scarring, that there is usually better distribution with the deeper block. But that really hasn't changed our practice, and we continue to do this much more superficial block, but we might do a couple of sites of injection. So what I mean by that is this is a sonoanatomy. So I typically use my probe like this, although you can do it in the transverse. And sort of the flow of the room is the person who's putting the central line in, I might be working with a fellow or working on my own, is I'm gowned and gloved for the central line. The neck is prepped, as is the chest, all the way down to the mid-abdomen. I have my drape. I put the central line in, and then I just cut the drape. It's a plastic drape. I just cut down here to expose this. I have the same ultrasound sterile cover. I'm using the same ultrasound, and the positioning is exactly the same. So you can effortlessly move from the central line to this very quickly, I must say. It really doesn't take up much time. And then this is the sonoanatomy C. So these are the ribs. This is the pleura. This is this very small muscle layer, which in children is very small for this deeper block. And I think that's one of the other reasons why this deeper block probably has more traction in adults than it does in children. And this is really where we try and target for the PECS intercostal block. So you can see here, this is transverse thoracic muscle. This is the greater pectoral muscle, and these are the ribs. And here's another shot. This is where we're trying to aim the local anesthetic in the block that I prefer, and this is the block that most of my colleagues do. This one here, although this is a block equally described, going to cover similar territory for the transversus thoracus muscle block. I have a video which shows you the hydrodissection quite nicely. This is a deeper block from the Japanese group, but you can see it really doesn't matter if your needle comes chordad or cephalad. You can see the needle on hydrodissection. There's the muscle plane. They've popped through the fascial layer. They're now retracting, and you'll see this injection of local anesthetic. And what you really want to see is this pleura depressed, as you can see here. And if you're doing it at the more superficial layer, what you'll see is this same kind of hydrodissection of fluid, but you see it up over the rib. So you actually see this kind of depression and creation of this potential space. You'll see up over the ribs. And this block will then spread over a couple of ribs, and that's why you get your dermatomal coverage between T2 and T6. Which is usually enough to make a significant contribution to your sternotomy wound. It's probably not enough, and in our experience, we have also started doing rectus sheath blocks for the chest tubes. We have a surgeon who does his chest tube centrally, and so that's great for the rectus sheath blocks. Peripheral chest tubes are not so great, and you might have to do a another kind of fascial plain block. But we also, want to be realistic here and share with you our standard anesthetic technique relies on some other adjuvants as well. We typically run low dose infusions of dexamethasone, which is an alpha agonist. I'm not sure if you have available to you in your country or in your hospital. It reduces MAC, and it's sort of a second generation clonidine, which I'm sure would also be contributory if you didn't have dexamethasone. Our typical opiate anesthetic is this block, and then we run infusions of fentanyl or a fentanyl derivative, depending on the anesthesiologist's preference. And then at the end of the case, we give acetaminophen, and we'll give one dose of ketorolac, which is an intravenous non-steroidal, if there's no concerns with bleeding. It's not especially specific, it's a non-specific non-steroidal. I'm not sure if you have specific ones at your site. What about the neonates? As I've already mentioned, we're not a particularly aggressive neonatal centre. I think many of the paediatric cardiac centres who are doing relatively early extubation, either in the operating room or early in the ICU, are not doing it for their neonates. There's obviously a couple of outliers. But for most of our practice, we'll keep our neonates intubated on their transition from the OR to the CCU, but we certainly have no concerns about extubating them at 6 hours after their operation or 12 hours after their operation. They just don't get extubated in the operating room. Surprisingly, there's not a lot of literature about the neonatal population, but there's this nice summary that comes from BC Children's relatively early in the sort of ERAS kind of protocols, and they describe their total set of 600 children. They're a significantly smaller site than we are, 97 of whom were neonates, and they extubated 70% immediately in the operating room, and then a further 20% within the first 24 hours. And when I read this paper, this was one of the papers that kind of reminded me to remind you and discuss in this context that you'll read things about early extubation in the title, and it's not till you get into the paper you realize they're talking about 24 hours, which, is earlier than we used to be, but, is certainly a different beast to extubating neonates in the operating room. When they drilled down in their data, they found that they had a reduction in length of stay and a reduction in hospital length of stay that wasn't really significant. And perhaps not surprising to any anesthesiologist, the patients that were difficult and kept their endotracheal tubes longer than 24 hours were the very small, those who are on postoperative inotropes and those who had been ventilated going into surgery. So clearly sick babies going in still come out as sick babies and don't get immediately extubated. Again, the BC group did a very small study of 10 neonates, which I think was just to prove that you could. And these are switches, 10 of whom were extubated in the operating room. They said this was safe, but I think if you're only studying 10 of anything, you really can't say that it's safe. All you can say is that 10 neonates worked. But even they would agree that this is not a big difference. And others have reported up to a 30% failure rate in extubating neonates and neonatal switches. So I think that's one of the other sort of take homes about this type of literature, is that there are people reporting, yes, we've done this and we were safe, i.e. we didn't have any problems, but the numbers are very small, and the differences are not very dramatic. And some of the differences are really related to your institution. So if, for example, when I go back to the previous slide, the length of stay is 1 to 3 days, and the hospital length of stay is 3 to 6 days. But if you're not looking at the whole process of your patient journey, then it may not really matter very much where they get extubated if they're getting held up in the journey further down the line, for example. But, there is literature, and this is a talk about early extubation. So the only other study I wanted to quote was a consortium of critical care hospitals. So these are 14 centres and 900 neonates. So this is the only really big paper out there that I can share with you. And they extubated then 60% of their neonates after cardiac surgery within 24 hours, which I think would probably be perhaps a little more aggressive than our place, but we certainly do extubate a significant number of neonates in the first 24 hours. 11% failed. And those that failed, the only really identifying feature is that they had an airway anomaly, which increased the likelihood of them failing. So I'm sort of wrapping up now so that we can have some time for questions. But I think when I look back at our experience over several years and the things that have become important to our centre and to me, is that we didn't start this overnight, that this was an evolution over time that was prompted by some pretty significant kind of staffing challenges in the ICU and getting patients through, but also wanting to speed up our patient journey through the whole process. We started with the pretty easy wins, and we are progressively expanding our population. So I think the Glens and the Fontans are pretty easier place to start because there are quite compelling physiological reasons to extubate them. It does take patience and time to bring everybody along, and this is essentially an exercise in change management. And so whilst you can work on your anesthesia group and the staff in the operating room and get them on board to adopt this new practice, you really also need to focus your efforts on everybody else that the patient encounters. So in the ICU and the ward, then come to accept patients who are more recently discharged from their surgery and from their unit. And so even the cardiology floor needs to be on board for this program as well. At the time when we instituted this, we had a couple of very vocal cardiac surgeons who were real champions for this, and they really wanted this to happen. And so we had, for many sort of staff meetings and group meetings in both the ICU and on the floor and in the operating room, this concept of acceptable failure. And so what they were working on is creating a culture where if you extubated somebody and it failed and they were reintubated, there was really no blame attributed to that. And it was almost presented that, you know, if we don't have a reasonable number of failures, then we're not trying hard enough, and that we should be trying to extubate more and more patients. I think the number of acceptable failure really depends on your site and depends on the rescue measures and the people that you have available to you and to your patients who can step in should there be a failure. And I talked a little bit about that earlier on, but you do need to recognize that if you are pushing this and trying to aggressively extubate patients, even in the best of hands, there are going to be patients that this didn't work out and they're going to need prompt reintubation. And so you want to have a system in place that you can do that, and a group of people that feel comfortable doing that, and there's no shame in making the efforts. We don't have blanket policies, so we still, you know, the official word is we leave it up to the discretion of the individual anesthesiologist. My sense is that most anesthesiologists don't like being told what to do, and I think I can say that because I am an anesthesiologist. So we have a heart center philosophy about early extubation. And we certainly try very hard, but even within our own group, we've had, you know, there are some people who've adopted this earlier than others, and we respect everybody's professional opinion as to what they think is the best for their patients. But what I have noticed is there's a real philosophy shift in that in the early days, the question was, well, why should I take this endotracheal tube out in the operating room? And you'd have to have a list of reasons in your head as to why you would do that. And now we're at the place where it's like, well, actually, why should we leave it in? And so whereas before we used to make an active decision to remove the endotracheal tube, now we're actually making an active decision to keep it. And that's been a real shift for us over probably the space of 5 or 6 years. So I'm going to leave it there. We have plenty of time for questions. I hope it's, you know, it's stimulated some discussion, and I'm happy to take any questions or any comments that you might have. Thank you.
Thank you, Professor Kathleen, for this comprehensive knowledge. If anyone have a questions, please raise your hand to ask or text the message in the chat box.
Can you hear me? I'm Professor Sunirat Kongseripong.
Yes.
Yes, thank you.
I'm Professor Sunirat Kongseripong from Ceylon Hospital, Bangkok, Thailand. Oh, this is an excellent talk. And I have to congratulate you for your hard work to extubate this kidney after the cardiac surgery. And I agree with you that patient selection is very important. And also the teamwork is also important. And for me, pain relief and hemodynamic is more than important in all of the patients. And extubation in the neonatal patients is also an challenging problem because as not only the cardiac anesthesiologist and pediatric cardiac anesthesiologist, and also I'm a pediatric anesthetist also. So we so concerned to extubate the neonate after all the major operations. I have a question for you. How about your work for the failing patients that you need to reintubate the patient? What is the main problem, and can we overcome with that?
Yeah, look, it's a really good question, and thank you for your comments. I wholeheartedly agree with you. Like, I think there are some centers who are extubating neonates, and I kind of personally wondered to myself, I don't understand the why. And sometimes I think people just do stuff because they want to get published or for whatever other reason, because I don't really understand the medical reason to extubate a neonate in the operating room, particularly if, you know, if they're going to have some complications related to that. I think for most of our experience, the reintubations come from excessive sleepiness, really. You know, we try at the end of the surgery when the drapes are off, we may have turned the anesthetic down for the last 15, 20 minutes. And we remove the drapes and clean the patient up. We might spend 10 or 15 minutes waiting for the patient to wake up. And if they look like they're awake and appropriate, then we'll pull the tube. But, you know, we all know there are some patients who take longer to wake up than others, even though you've given them exactly the same dose. And so some are just too sleepy and then they just end up obstructing, and that's difficult to manage. So we'll reintubate those. And that's typically the most common reason, that they're just too sleepy for us to feel comfortable leaving them in ICU.
Did you see any hypercarbia after you extubate the patients? Because the last patient that I early extubated, the team did not understand that, and they did not put the kid in the night position, so the kid had the airway obstructions afterwards. So we have to immediately intubate the kids, and 1 hour after that, we can extubate that.
Yeah.
So,
absolutely. And, you know, I think, I don't know what happens at your site, but like we, you know, our ICU nurses had to be taught how to manage the freshly extubated patients. And we have respiratory therapists here who manage the ventilator. And, you know, they were coming back and, you know, prior to this, they were used to patients who have completely normal end-tidal CO2s. And so they were ventilating people to CO2s of say 38, and the patients were taking longer to wake up. So it did take some education that, you know, patients immediately post anesthetic will have a higher CO2. Their CO2 responses will be blunted, and that you can't put them on their back and leave them alone and go and do whatever else you're doing, because they will obstruct. And so we did learn that ICU nurses are not recovery nurses. And so we had to do some cross-training, because recovery nurses are all about the recovery position and maintaining the airway and that kind of care. And ICU nurses have a different lens to bring to this. And so, yeah, we have had patients who obstructed because they were supine and not in the, you know, because that's easier for the ICU nurses. And so it does take some learning on both parts. For sure.
How often, this is my last question, how often you have to come up with the CPAP? How you select the patients? Because I'm the one that use CPAP a lot in not the pediatric patients, but in adult patients. But how about in pediatric patients? I think that might be another way to, like in between poses before we can really extubate or fully bring the patient to just nasal cannula. How you select the patients?
So the patients who get CPAP are usually the ones who look pretty marginal. So they may be patients for we have a strong reason that we want to extubate them. So, you know, I'm kind of thinking there might be a marginal Glen or a marginal, a marginal Glen or a marginal Fontan that we're really trying to get negative pressure ventilation. And we'll make a team decision and extubate them to CPAP. I must say, extubation to CPAP is a rarity. Like we would do it probably 5% of the time. And usually we do it with a discussion, like I'll ring the ICU beforehand and say, look, we've got this person who we're thinking about extubating. It's probably not going to be completely straightforward. And can we have the CPAP machine set up and ready to go? I think if you're extubating all your patients to CPAP, you kind of have to wonder, like, what's the advantage of that transition? But it's also extubating to CPAP is probably not something I'm going to do at 2 a.m. when there's only one, you know, the bare minimum staff in the ICU. So that patient who I'm worried about, I'll probably just leave the tubing and they can extubate them in the morning. So the CPAP thing is certainly something that we have available and we do use, probably more on a discretionary basis.
Okay, thank you.
I hope that's helped. Lovely to meet you. Thank you very much for having me.
Dr. Thilapong, please.
First of all, I would like to say thank you to you, Catherine. I really appreciate your time and contribution to this wonderful talk. I have some questions regarding your selection criteria. So based on what you have shown in your slide, so redo cardiac surgery and even second or even third bypass run or aortic clamps doesn't seem to be in your process of decision making. Do you have any comment on that?
Yeah, that's correct. So the literature that is available, it has duration of bypass has not come up as an independent variable for extubation success. So we don't use number of bypass runs or total bypass time. I recognize that sometimes that is a surrogate measure for poor hemodynamics and generally a patient who is very sick, but not always. And so we tend to use patient factors more than a total number of bypass runs or bypass time to determine extubation. If the patient is well perfused afterwards and all those other measures that I mentioned in the checklist that we use, then we will assess them, right? And assess their suitability for extubation and we may even extubate them and see how they go, for sure.
Professor Kathleen, I would like to ask you about the sedation. Do you sedate the patients after extubation in pediatric patient in ICU? And if so, which drug do you usually to use to sedate?
So they have dexamethasone has some sedative effects. The alpha agonist has some effects, and I don't know if you have that available to you. So that is some sedation that we would use, I would say probably 50% of the time. Most of the time, we just give them really good analgesia. So they get the blocks, as I mentioned, and we basically use the volume I mentioned. So we look at what's the toxic dose of local anesthetic for this patient's weight, and then we dilute it so that we can get the volume that we want, because these blocks are really about volume. And so it matters less if you have to dilute the local anesthetic, but you really want the volume for that spread. And then typically with these blocks, I might load the patient before I extubate them. I'll give them 50 mics per kilo of morphine. And then I'll get them spontaneously breathing as the surgeon's closing the sternal wound and doing the final sutures. The patient will probably be spontaneously breathing, maybe on some pressure support. My MAC is probably 0.3 at this stage, 0.2, because I've got the block, I've got some residual anesthetic. I've given them 50 mics per kilo of morphine. We take the drapes off, wipe them down, clean up the blood, probably pull the tube at that stage. And then I'll titrate the some more morphine. Typically, it's probably up to another 50 mics, I find. So it's about 100 mics for the average sort of Canadian child. And then they get some acetaminophen and that's it. And then they go to the ICU and they'll get PRN morphine intravenously as they need it. They'll get regular acetaminophen or paracetamol, I'm not sure what you call it. And they get 1 dose of a non-steroidal. And that's typically about it.
I'm Professor Sunirat again. I just have the questions about the block that you use it. Who did the block and how long that the regional block work?
Okay, good questions. So the anesthesiologist does the block, or we often work with a trainee, so they'll do the block. Typically the flow works is that we have to gown and glove to insert central lines here and we use ultrasound. So I'll be at the head of the bed, for example, I'll put the central line in using the ultrasound probe, then I'll dissect down with the drape or I'll move the drape open and I'm at the sternum somewhere between T3, T4, sort of rib level, rib number 2 and rib number 3 rather. And I have the probe vertically and I have the needle at the head and then I just inject using that probe and get the dissection. It probably adds another, I don't know, 5 minutes. T can attest how long it takes. I use bupivacaine because that's what we have here, but you can use ropivacaine or whatever else you have. We put some dexmedetomidine in the local anesthetic. I know other places put other adjuvants in the local anesthetic. We estimate anecdotally, and I don't have great evidence for this, that we probably get between 12 and 16 hours of analgesia from that alone. And patients report very low pain scores, and there's some other literature of other centers also reporting very low pain scores. So we usually, I would say probably 12 to 16 hours. If you get a nice hydrodissection where you can see the planes going up over the ribs, then I think you've got a good couple of, half a day probably of analgesia. What I'll sometimes do in a very long case, like if it's a 12-hour case or something, I'll do the block at the end. So, because there's probably not much point in having 12 hours of the block effectiveness during the anesthetic and during the case. And Dr. T and myself have done that. As he's closing, I've scrubbed in at the end and put the block in just before about to take the drapes off at the end of the case.
Dr. Kittipong, please.
Hello.
Hello.
I just would like to know that what kind of personnel that in ICU to evaluate the patients, whether or not they can make it, and who makes the decision to get a tube in. And the second question.
Yep. Sorry, the second question. Yes, please.
The second question is that what is the turnaround time in the operating room? Does it make kind of slow down the OR turnover time?
Yeah, both good questions. So I'll extubate and then I usually spend sort of maybe 5 or 10 minutes after extubation in the operating room, making sure the patient's all right. And at that time, transferring the patient over from the operating room bed to their actual bed. And we're transferring the monitors over to the transport monitor. And during this sort of transfer time, which was going to happen anyway, I'll be assessing the patient to see how they're going. And I must say, most of them, you know, if they're going to fail, they'll fail pretty quickly. The people who, you know, have this slow creep and they slowly increase their carbon dioxide and they slowly sort of become more somnolent and obstructed, as the other professor mentioned earlier, those people are managed by the ICU. And we find that's less often because once the patients arrive in the ICU, you know, there's lots of monitoring and people are doing temperatures and fussing all around them. So they're not really left alone for an hour or two as they're being admitted into the ICU, and that usually is enough to sort of keep them awake and breathing. What I don't do is I don't sort of sit around at the end of the case for an hour seeing if I can pull this tube. So I usually give the patient, you know, 10 or 15 minutes once we've transferred them over. And if they look like they're ready to be extubated and I've turned everything off and I have encouraging signs that they'll be able to manage their airway without an endotracheal tube, I'll extubate them. But if we're at sort of 15 or 20 minutes and it's not looking promising, then I will send them over to ICU, hopefully spontaneously breathing, and the ICU can extubate them here in the ICU. So I think what we've done is early extubation is not just the responsibility of anesthesia, it's the whole program. So the ICU are also encouraged to get their tubes out early. And so if for whatever reason we are unable to, we still try and get the tube out as soon as we can, but I'm not holding up an operating room for an extended period of time, just so I can be the person to extubate them. There's someone else along, you know, the next person who assumes care is also under the same kind of, you know, works from the same philosophy that we want to get these tubes out as soon as we can. And so I don't think it delays our turnover that much because we don't let it. Frankly, we're not sitting around waiting for an hour for a patient to wake up. I hope that answers your question.
Yep, thank you.
Yeah.
Okay. Another question I just want to ask the surgeon, CVT surgeons. I would like to know about the surgeon's perspective about the extubation in the operating room. Dr. Thiraphong, you can answer this question or show the opinions about that.
I think one thing that prevent us, I mean, in Bangkok, to do that, I think one major thing is how to ensure that the patient is going to be doing good enough after the OR. So one thing that I have seen the different from CRAT and SickKids is we perform here in SickKids intraoperative echocardiogram. So we intubate the kid nasally and we put a TE probe into the stomach and to show, and if that is not good enough, we do epicardial echo to make sure that no significant lesion left with the patient. So with that, I think almost guaranteed that most of the patient gonna be doing okay after the surgery. This is one of the my observation. And for me personally, I okay with early extubation and encourage everyone to follow. Thank you.
Okay, thank you. Another question.
Hello.
Dr. Noppanan, yeah.
Hi, I'm Noppanan. I'm the anesthesiologist. Thank you for your excellent talk and the way you highlight the fact that this is a team effort, not an individual anesthesiologist or anything like that. My question is, I have two questions. One is that, can you describe more how, in your experience, how did you transition from not extubated at all to like extubated criteria? For example, at the beginning, do you have like any criteria? For example, easier operations, for example, ASD, VSD closure, or any cutoff points for the age group. And my second question is that how did you find it easy enough in terms of the learning curve of the PEG blocks? Because we all know that once you learn something, for example, like the new block, you will have the learning curve. In your experience, and anyone who the block did not work, or how long does it take for you to actually master the block and be able to be confident? Thank you.
Both great questions. So I think when you're introducing any change, you know, you want to have some wins early on. You know, it's good to have some successes. So I think you choose the patients in the beginning who you think, and you're going to know this from your anesthesia practice, who are more likely to succeed. So, you know, children who have had pretty straightforward operations, aren't in bad heart failure, are generally pretty robust, is a good place to start. I think the Fontans and the Glens are good places to start, because there are very good reasons that the whole team understand why you want this patient spontaneously breathing. And so there's a team incentive to get them to that place. So I think that makes the sell of this very easy. And as I hope I've conveyed in the talk, like we're happy with the people we're extubating right now. We've no desire to pursue the neonatal edge. Like, you know, I think you as an institution, as a group, decide what you're comfortable with your local resources and your local culture. Okay, so we've decided that, yeah, we know there are places that extubate neonates and Norwoods. We're not going to be that place, and we're okay with that. We started out where we wouldn't extubate tetralogy for low, which here we typically do about 5 kilos, but as you can see from the earlier slide, we extubate about 63% of tetralogies. So that was a group that we've really sort of, initially we were very uncomfortable, and then we were, as we got more confident, we were like, oh, okay, well, let's try this. And certainly there's some good physiological reasons for extubating or having a tetralogy spontaneously breathing if they've got quite restrictive physiology on their right ventricle. There's some compelling reasons to get them spontaneously breathing. So I think when you have patients like that and you set the team up for success, so middle of the day, make sure everybody knows, it's not a surprise to the ICU, they've been given the heads up beforehand, there's nothing else going on, there's no residual lesions, the patient's warm, there's not a lot of bleeding, everything else looks pretty good, then that's probably the person to start extubating. In terms of the blocks, I mean, you know when the block works because you see this lovely hydrodissection. And I said in my disclosure, I am not a block guru. Like, there are some people who have this beautiful hands and they're really good at blocks. I am not that person. I'm sort of at the end of my career, and I have 2 colleagues who are older than me. And we have the whole group of 8 of us all do these blocks now, with, I have to say, probably being taught by our fellows, you know, our trainees who've come and done these blocks. You'll often find with your trainees, they're doing these blocks in their adult rotations, because this is a block that's preferred for multiple rib fractures and traumas. It's a block that's also done in breast surgery, breast cancer surgery. So this block and similar blocks, so the pecs 1 and 2, which are also underneath the pectoralis muscle, but just a bit further lateral from the sternal margin, are all kind of in this group of fascial plane blocks, and they're all considered sort of entry-level blocks for every anesthesiologist. I would hazard a guess that if you're comfortable with an ultrasound and you do some blocks like rectus sheath blocks and tap blocks in your practice, you would probably need less than 10 to feel comfortable to do this. Like, it really is pretty easy. The mistakes you can make, you can inject into muscle, and you know that because you can see in the ultrasound, you get this thing that looks like lots of fascicles, and you don't get the nice hydrodissection. It's hard to inject. So when your assistant is injecting, they say, oh, look, it's really hard, and then you stop. So that's a problem. You could be in a vessel, but if you stay superficial, there's really not a lot of vessels there that, you know, you're going to get your you're going to get lost and inadvertently have your needle there. And you aspirate every mil or so that you know you're not in a vessel. You will see a little blip on the skin, particularly for the babies. If you're putting 5 mil either side, you're going to see a little blip, and we just massage that in. The surgeons will tell you that they might see it in the tissue planes, but it is, I have to say, it's a pretty easy block. And I'm happy if you would like another session on blocks, we could do that for sure.
That is very convincing. I will definitely start learning about the blocks and probably start doing that today.
Yeah, well, look, I encourage you. And look, if we're happy, if you would want to session on blocks, we can do that. Or, you know, I have other people who are much better than me who can arrange time to teach you. Or there are YouTube clips from NYSORA or ASRA or any of those organizations will have clips on it. And yeah, I mean, I would encourage you to do it. I think if you've got good ultrasound skills and you stay superficial, I think the deep block is a bit treacherous, and I personally don't do that for the reasons I've outlined, but I think the superficial block's pretty safe.
I'm not sure there are some questions from Siddharth conference room. Just raise your hand before, but
yes,
yeah.
Hi, I'm Pranya again. I was gonna ask, but then I looked into the publication and found out that they can also use the PEG block in adult cardiac surgery patients.
Yes.
But then I come up with another questions, actually, and this is a question from the surgeon, not from the anesthesiologist, so it could be not a good question.
Not at all, not at all.
So if you mentioned about a superficial PEG block, so what about if we use like a EMLA cream? You know that the local anesthesia that is applying, not can they, is there any paper or anything look into that kind of way of eliminating the pain?
So no, I haven't seen any papers for that. I think one of the challenges for EMLA cream will be the dose for the length of the incision and keeping it there. You know, you have to wipe it off and give more. So I mean, I haven't seen any literature for EMLA cream for children. There is some more studies in these blocks in adults for cardiac surgery. And there's a couple of groups. There's one randomized trial of 80 patients that showed a reduction in opiate consumption and length of stay. Often the reductions are not especially significant, I'll be honest. The pain scores and satisfaction and all those sort of soft measures seem to be favorable for the blocks. For adult cardiac surgery, and I recognize that adults having cardiac surgery have a whole lot of other things that might affect some of these results. But certainly these blocks are being used in, you know, the COPD patient with multiple rib fractures and managing them in ICU, particularly if you don't want to intubate them and put them on a ventilator because they may not ever be able to be extubated. So sort of managing those difficult patients where you don't want them to get respiratory failure, but the rib fractures are really causing a lot of pain. You can do these blocks for those. And some people are doing catheters and then infiltrating through catheters, a bit like an epidural kind of system. We don't have that experience here. And then there's a question about, have I ever used caudal morphine? I haven't personally. We don't do that for cardiac surgery at our site. But I did publish a systematic review on caudal morphine in pediatric cardiac surgery probably 5 years ago, reviewing the evidence about it. Probably my understanding of the literature then, and it may have changed, is that there's a few groups that are real devotees. There's a Swedish group that are doing thoracic epidurals, and they're also doing caudal morphine. But many people don't want to put a needle anywhere near the spinal cord in light of the heparinization of cardiac surgery. And I didn't mention that for these fascial plane blocks, but the reason, I guess, regional anesthesia has been so slow to find its home in cardiac surgery is that everyone's been concerned about heparinization for bypass and causing bleeding and epidural hematoma. And so that's what's really prevented us from embracing regional anesthesia. And the thing about these blocks is that this is an avascular plane. And so You know, as long as you don't inject local anesthetic into that internal mammary artery in the deep block, you're very safe. And so you can heparinize patients for bypass within 20 minutes of inserting this block without any concerns. And I think that has made these a real game changer.
Thank you.
My
Okay,
pleasure.
okay, I think it's enough time. Thank you very much, Professor Kathleen, and thank you
Thank you very
everyone
much.
thank you everybody to join us today. Be happy on the rest of your days. Thank you.
Well,
Goodbye,
thank you. Thank you.
สวัสดีค่ะ
It was super fun. Thank you very much. Thank you. Bye-bye.
Thank you. Have a good day.
You too. Bye-bye.
Bye.
Bye.